Well, good afternoon. I would like to introduce my PhD topic, which is about the conservative therapeutic possibilities for extra and intra-articular temporomandibular disorders. My name is Kata Kelemen, and I'm from the Department of Prosthodontics. My vision is to establish a TMD protocol that is available for all patients, apart from the dental offices. And my mission is to make an emphasis on the prevention and also on the therapy as well, and to have a proper funding to increase the level of evidence. Here you can see my specific goals. My first one is investigating the efficacy of additional occlusal splint therapy to physiotherapy in adults with myogenic temporomandibular disorders. And as about its background, temporomandibular disorder is the third most common stomatological disorder, and the 10th or the 15% of the population has this kind of disorder. And the most common type is the muscle disorder group, which can be about 45% as well. And its therapy we can use whether an occlusal splint therapy or a physiotherapy as well. And the unmet need for this topic is to find a pain relieving method. So our aim is to investigate which reversible and conservative therapy offers the best results in decreasing the TMG symptomology. So our question is there a difference in efficacy of additional occlusal splint therapy to physiotherapy in adults who have myogenic temporomandibular disorders? The intervention would be the additional splint therapy to physiotherapy, manual exercise, education, and counseling. And we would like to compare these to physiotherapy, manual exercise, education, and counseling as well. Our hypothesis is that additional occlusal splint therapy offers a best results, so it's more efficient. I have done the systematic research in 4 databases, and here you can see my search key as well. And I have found more than 800 records before the duplication removal, and after the whole process, 7 articles were eligible that were included in our meta-analysis and in our systematic review as well. As the TMD symptomology has 3 main symptoms, the first one is the movement restriction. And as this is an objective outcome, we can measure it whether with a ruler or a caliper in millimeter. So we should consider it as a primary outcome. And the second symptom is the pain perception, which is much more subjective, so it should be considered as our secondary outcome, and it can be measured on a visual analog scale, which is from 0 to 10 units. And the third one is the sound effects, but unfortunately we could not find any articles that were eligible, so we did not include it in our meta-analysis. Also, we added another secondary outcome, which was the quality of life. Here you can see my first outcome, which was the pain perception on a visual analog scale at the 4 weeks follow-up. 4 articles were included, and the population is quite homogeneous. The effect is 0.03, which means that neither clinically nor mathematically this is a relevant data. My second outcome was the maximum mouth opening at the 4 weeks follow-up. Unfortunately, 2 articles were included. The population is also homogeneous, and the effect was 1.11 millimeter, and that's also neither mathematically nor clinically relevant. We have also analyzed the pain perception on a visual analog scale at the baseline and at the 4 weeks follow-up between the intervention and between the control group. And here you can see that 5 articles were included. The population heterogeneity is quite big because of 1 article, that's the last one, at the Kucha et al., because in these cases painkillers can be prescribed, so that's why it can modify our results. And mathematically, the effect was significant, and also clinically as well, because it means that in the additional splint group, the pain perception decreased with 2.54, and at the physiotherapy group, it decreased with 2.33. And also, we can observe a little change between the intervention and the control group. So that can questioning the usage of the splint therapy. And here we compare the maximum mouse opening at the baseline and at the 4 weeks follow-up between the intervention and the control group as well. 2 articles were included, and the population has a bigger heterogeneity. It was actually quite high because of an article in which not only myogenic patients were involved, but also some arthrogenic patients as well. This means that it's mathematically not relevant, but clinically this is a significant result. Here you can see my summary. As the implication of for practice, we should reconsider the usage of the splint therapy as the first non-invasive therapy in myogenic TMD. We should also involve a multidisciplinary team and involve more physiotherapists in the field. The implication for research is that more investigations should be done, especially on the splint therapy. So in which condition is the most efficient alone. We should do a research on pharmacotherapy as well, and we should restrict the inclusion criteria, as psychosocial conditions can affect the outcomes as well. And also it would be beneficial if we can make a subgroup analysis of the TMD classifications. The strengths of our systematic review and meta-analysis is that all the included studies were randomized control trials, the exclusion criteria was quite homogeneous, and all the articles were using the diagnostic criteria of TMD. We included a long-term follow-up as well, and in all cases the additional splint was the Michigan splint, which was adjusted to the upper maxillary arch. The limitation of this work is that there was only a few articles, there was a quite big heterogeneity in the population, and the physiotherapy was conducted under different settings, and some of the exercises were done at home, and we could not control these works. So the outcome mainly depends on the patient's motivation and on the patient's compliance. So the conclusion is that there was a small mean difference change between the intervention and the control group as well. So that can questioning the usage of the splint therapy in myogenic TMD as the first non-invasive therapy. We should make a bigger emphasis on physiotherapy as well. We should involve more physiotherapists in this field, but also to distinguish the results, we should implement more RCTs in the field. And you can see my second topic, which is investigating the efficacy of platelet-rich plasma over hyaluronic acid, steroid, and Ringer solution as well for TMG osteoarthritis. The 8 or the 16% of the population has this kind of disorder, and arthrocentesis is an intermediate place between the conversional and the surgical forms as well, and it can be done under local anesthesia as well, and the unmet need is to find a pain relieving method. So our aim is to investigating the efficacy of PRP over HE, steroid, and Ringer solution as well. Our hypothesis is that PRP is more efficient than HE, steroid, and Ringer solution as well, and we would like to make a network meta-analysis, so there would be more interventions, the PRP, HE, and the steroid as well. The primary outcome would be the range of motion that can be measured with the caliper, and the secondary would be the pain perception as well, and it would be also beneficial if we can detect the negative outcomes as well. I have done the preliminary research in 4 databases, and so far I have found more than 1,000 articles. I have done the title and abstract selection, and according to the full text, we have found 27 eligible articles for this network meta-analysis. I would like to finish both of my reviews till July, And thank you for your attention. If the plan does not work, change the strategy, but never the goal.
Thank you for this nice presentation. First of all, I have one question because I can feel myself that I'm an expert in the second topic and the first topic as well. You know, you mentioned the different materials that we can use for the injection, intra-articular injection. How is at this range or scale, because the injection is one option, but the arthrocentesis it's another options, which has a high efficiency rate in the therapy, non-invasive therapy before the invasive therapy. This is my first questions. And on the first half of your presentation, you mentioned that the Michigan splint. And could you tell me what was the summarizations of the Michigan split? How is the best, you know, bite elevations with the Michigan split? Because these patients had only myogenic background, myogenic complaints. What is the general recommendation and suggestion in terms of the bite elevations with the Michigan splint in case of the myogenic lesions?
Thank you for your questions. Well, I will start with the second one. The Michigan splint was always adjusted on the maxillary arch, and it was also adjusted all the time to the centric relation. And the requirement for this setting was that during the protrusive and during the laterotrusive movements, there should be also always a canine guidance. So that's how the doctors and the experts adjusted these splints. And the other question was, we would like to examine which medical device is more efficient during the TMG osteoarthritis.
And are you planning to make more investigations with the fat tissues, you know, the cell fat tissues, because you know, in case of the PRP, you know, the cells is the most important, you know, for the high regenerative effect. Okay, first question oriented that how many millimeters is the thickness of the Michigan split, because this is very important questions when we are planning to making this treatment therapy. This is always a good, very important, relevant questions. And if the patient has a myogenic lesions malady, in case of this, the point of the emanating points distance is always a very important question. Thank you for your answer. Turning to the audience who has any other questions.
There is a difference, the second topic is yours. There is a difference between the occasion you have to apply these therapeutic options in time. I mean, how many times you have to do, and there is a difference between maybe them.
We are repeating all the injections once a week, and after that the patient should come every week for 3 times, and then for the follow-ups only. So there is no big difference between the times.